Welcome back to the deep dive. We're here again taking those really complex clinical guidelines, dense research, technical manuals, and boiling them down into the practical knowledge you need fast. Today, we are diving deep into, well, the language of labor itself, fetal health surveillance, or FHS.
Absolutely. And this is probably one of the highest stakes areas in acute care you can find maybe outside the OR. FHS is that process, sometimes continuous, sometimes intermittent, that we use during labor to figure out how the baby's doing physiologically. Our main goal, the immediate one, is to spot potential fetal decompensation, specifically hypoxia, lack of oxygen, and hopefully reverse it quickly to prevent really serious, life-altering outcomes or worse.
Right, and our sources today are those incredibly detailed clinical guidelines that, nurses and doctors are relying on minute by minute during labor. So our mission here is to give you a really solid toolkit. We want you to understand the two main ways we monitor, IA and EFM, and crucially, how to interpret the signals the fetus is sending. It's like decoding the secret language of the heart strip.
Exactly. We have two main approaches to guide us. First, there's intermittent auscultation IA. That's the less invasive, more hands-on method. And then there's continuous electronic fetal monitoring, or EFM, which gives us that constant data stream most people probably picture when they think of labor monitoring.
And that initial choice is pretty critical, isn't it? Which method do you start with?
It really is. The guidelines are quite clear. If the pregnancy is term, everything's looking good, no underlying worries or risk factors, then IA is actually the preferred way to go. It's less invasive and generally promotes better labor outcomes in those situations.
Okay, let's start there then, with intermittent auscultation, IA. It might sound like the simpler option, but you're saying its benefits are actually quite profound, especially for the patient's experience. What makes it preferred for low-risk labors?
Well, the big advantages of IA really center around promoting a more positive and physiological labor. Because the mother isn't constantly tethered to a machine, she has much more freedom of movement, more autonomy. She can walk around, change positions easily, use gravity, things that often help labor progress more naturally and sometimes more quickly. Plus, it's inexpensive, easy to use, and this is key from an outcomes view. IA is linked with significantly fewer unnecessary interventions. We're talking fewer C-sections, fewer forceps or vacuum deliveries, especially when you compare it to continuous EFM in those low-risk scenarios.
But it's not just like a quick listen in here and there, right? The sources really stress that the technique has to be rigorous to actually be useful clinically. How exactly is IA done correctly?
Oh, absolutely. Precision is key. When the nurse or midwife uses the Doppler or maybe a fetoscope, they have to listen for a minimum of 60 seconds. And I really want to stress that minimum. You're not just grabbing a quick 5-second heart rate. No, you're auscultating carefully to establish one single, reliable baseline number for the heart rate. And at the same time, you're actively listening for whether you can hear accelerations, those clear, audible speed-ups or decelerations, the audible slowing of the heart rate.
Okay, 60 seconds, baseline, accels, decels. What about the rhythm? What if it sounds irregular, not steady?
That's a critical finding. If the rhythm sounds irregular, that could signal a fetal arrhythmia, a heart rhythm problem. And that is an immediate non-negotiable reason to stop IA. The nurse absolutely must initiate continuous EFM right away to get a detailed visual tracing of that pattern, and of course communicate that urgently to the doctor or midwife. An irregular rhythm needs a much closer, specialized look.
That makes total sense.
Yeah.
Okay, so IA isn't just about the heart rate. You also have to assess uterine activity, UA, at the same time, right? By palpation.
Exactly, they go hand in hand. While listening to the fetal heart rate, the practitioner must have their hands on the mother's abdomen to feel the contractions. They're feeling for three things. First, frequency. How often are the contractions coming? You measure from the start of one to the start of the next. Second, duration. How long does each contraction last, from beginning to end? And third, strength or intensity. This is subjective with palpation. Is it mild or weak, meaning you can easily indent the uterus, moderate, where there's some resistance, or strong, where the uterus feels really firm, hard to indent?
And within that palpation assessment, there's that really crucial element sometimes overlooked when we just focus on the contractions themselves, which is the resting tone.
Yes. The resting tone is, you could say, the fetus's lifeline between contractions. It's that period when the uterus should feel completely soft. We really emphasize this because that relaxation phase is the only time the fetus gets to properly reoxygenate and clear out waste products via the placenta. If that resting tone stays high, or if the contractions are just coming too fast, bam, 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 or lasting too long, that recovery window shrinks or disappears. And the risk of hypoxemia, low oxygen, goes way up fast. Assessing resting tone isn't optional, it's essential.
Okay, so because IA is intermittent, not continuous, the timing, the frequency schedule, that's basically the safety med, isn't it?
Sure.
How often does IA need to happen as labor progresses?
Right, the schedule is everything.
Right.
And the frequency ramps up significantly as labor intensifies. So, on admission, let's say the patient is low risk, stable, maybe just admitted to the hospital. IA is generally done about every hour or so. But once she moves into the active phase of the first stage of labor, contractions are getting strong, regular cervix is dilating more actively, then vigilance needs to increase. IA should happen every 15 to 30 minutes.
And then for the second stage, the active pushing phase, that's often the most stressful part for the baby physiologically.
Exactly. At that point, the frequency becomes almost constant vigilance. The standard is every 5 minutes. Or, and this is key, immediately after each and every pushing contraction. The forces involved, both the uterus contracting and the mother pushing, put maximum stress on the baby's cardiovascular system. The risk of a significant drop in heart rate, a deceleration, is highest then, so you need that hypervigilance.
So let's say the practitioner does detect something concerning during one of these checks, maybe a deceleration is heard, or that irregular rhythm you mentioned. What's the protocol then? Do they immediately switch to EFM?
Not necessarily immediately, there's a structured flow chart. First, the nurse should quickly try some appropriate intrauterine resuscitation techniques. Often, the simplest and most effective thing is just changing the mother's position, rolling her to her side, for instance. That can sometimes relieve pressure on the umbilical cord or improve blood flow back to her heart. After doing that, they must listen again to the fetal heart rate immediately after the very next contraction. If, after that quick intervention, the heart rate doesn't immediately return to a normal, reassuring baseline, that's the trigger point. That's when they need to initiate continuous EFM to get a full tracing and obviously let the provider know what's happening.
Okay, that leads us nicely into EFM, electronic fetal monitoring. This gives us that continuous visual data stream, right? It seems like it would catch hypoxia that might be missed between those intermittent IA checks. But you mentioned a trade-off right at the start. If EFM gives more data, why do the guidelines and studies note it's associated with higher intervention rates? That seems a bit counterintuitive.
It really is the central paradox of modern FHS, isn't it? EFM provides this constant, relentless stream of data, every little wiggle, every tiny dip in the heart rate. And because you're seeing everything, you often pick up on, let's call them benign fluctuations or transient changes that might have just resolved on their own and gone unnoticed with IA. But clinically, when a provider sees a pattern that looks even slightly non-reassuring on that monitor, the impulse driven by caution, maybe fear of litigation too, is often to intervene, even if the baby isn't truly in trouble. And the result, according to research, is definitely an increased rate of C-sections and instrumental births compared to using IA, particularly in low-risk women, without necessarily showing a clear improvement in overall long-term outcomes for the baby. So it demands really skilled interpretation, not just reaction.
Got it. Okay, let's break down external EFM first. What are the gadgets placed on the mother's belly?
So externally, we use two main sensors or transducers. The first one is the ultrasound transducer. This uses Doppler ultrasound waves that bounce off the fetal heart valves to detect and calculate the fetal heart rate, the FHR. The second one is the TOCO transducer or tocodynamometer. We usually just call it the TOCO. This is placed on the top part of the uterus, the fundus.
And the TOCO has a really important limitation, doesn't it? Something clinicians absolutely need to remember.
Yes, crucial point. The TOCO measures the tension or tightening of the uterine muscle through the abdominal wall, so it's pretty good at recording the frequency of contractions, how often they happen, and the approximate duration, how long they last. But because it's external, it absolutely cannot measure the actual strength or intensity of the contraction in objective terms, like millimeters of mercury. That intensity still has to be figured out the old-fashioned way, by the nurse putting their hands on the abdomen and feeling at palpation. Another practical issue is that these external monitors can slip. They often need frequent readjustment, maybe every hour, or basically any time the mother or baby shifts position significantly, just to maintain a good quality signal.
Okay, so if that external tracing isn't reliable, maybe the signal quality is poor, or if the situation is higher risk and you really need that objective, accurate data, then we move to internal EFM. You called this the gold standard for accuracy. What needs to happen before you can place internal monitors?
Right. Because internal monitoring is invasive, there are a couple of prerequisites. First, the amniotic membranes, the bag of waters, must be ruptured, Bricken waters. And second, the cervix needs to be dilated enough, usually at least 2 or 3 centimeters open, to allow the devices to be inserted safely past the cervix without causing trauma.
And what are those internal devices that give us that truly objective information?
For the fetal heart rate, We use a fetal spiral electrode, often called an FSE or scalp electrode. It's a tiny corkscrew-like wire that's gently attached just under the surface of the baby's presenting part, usually the scalp. This picks up the fetal EKG signal directly, giving a very accurate beat-to-beat FHR tracing, much less prone to signal loss than the external ultrasound. And for monitoring the contractions, we insert an intrauterine pressure catheter, or IUPC. This is a thin, flexible catheter that goes up into the uterine cavity alongside the baby.
And the IUPC is the key for objective measurement, right? Because it directly measures the pressure inside the uterus in millimeters of mercury. How does that translate into useful clinical data?
Precisely. The IUPC gives us objective numbers for frequency, duration, and intensity of contractions. Crucially, it also gives us an accurate measure of the resting tone, the pressure in the uterus between contractions. This is super important for diagnosing issues like uterine hyperstimulation, where the uterus isn't relaxing enough. And that intensity measurement, the peak pressure during a contraction, allows us to calculate something called Montevideo units, or AVUs.
Ah, MVUs. Let's dig into those. They quantify how much work the uterus is actually doing, right? Yeah. How do you calculate them, and what do the numbers tell you?
Yes, MBUs are a way to objectively measure the total strength of labor over a set period. The standard method is to look at a 10-minute window of the tracing. You identify all the contractions within that 10 minutes. For each contraction, you take the peak pressure it reached and subtract the baseline uterine pressure, the resting tone. Then you just add up those pressure differences for all the contractions in that 10-minute window.
Okay, so let's say, hypothetically, in 10 minutes you see 3 contractions. The resting tone measured by the IUPC is 15 millimeter Hg, and the peaks of the contractions hit 65, 70, and 60 millimeter Hg. You calculate 65 minus 15 plus 70 minus 15 plus 60 minus 15.
Exactly right. So that's 50 plus 55 plus 45, which gives you a total of 150 MVUs for that 10-minute period. Clinically, the guidelines suggest that adequate labor contractions in the active phase of the first stage usually generate MVUs somewhere in the range of 100 to 250. Then in the second stage, the pushing stage, the uterus typically works even harder, and you might see MVUs up around 300 to 400.
And this MVU number is really helpful because it can help diagnose why labor might not be progressing, right? If someone's getting oxytocin like pitocin to strengthen contractions, but the MVUs are still low, say consistently under 200.
Precisely. It helps diagnose inadequate uterine activity. If labor isn't progressing, the cervix isn't dilating, the baby isn't descending, and the MVU calculation is consistently staying below that 200 or 250 mark, even with what seems like a good dose of oxytocin. It tells you objectively that the uterus just isn't generating enough power, enough contractile force to get the job done. That insight, which you can only get accurately with an IUPC and MVU calculation, often becomes the objective evidence needed to diagnose certain types of failure to progress and decide on next steps, like maybe increasing the oxytocin further or considering other options.
Okay, so now we have the tracing, whether it's from external or internal monitors. The first thing we need to figure out is the FHR baseline. What's the precise definition? How do we nail down that baseline number we rely on?
Right. The baseline is fundamental. It's defined as the approximate mean or average fetal heart rate, rounded to the nearest 5 beats per minute increment observed during a 10-minute segment of the tracing. But here's the crucial part. To establish that baseline, the rate needs to be relatively stable for at least 2 minutes within that 10-minute window. And importantly, we have to deliberately exclude any periods where there are accelerations, decelerations, or times of marked variability, those really big swings. If the tracing is so unstable that you can't find at least a 2-minute segment that looks representative within that 10 minutes, then the baseline is considered indeterminate. You can't confidently call it.
Makes sense. And what's the normal range we're looking for in a term baby? And what's actually controlling that rate physiologically?
For a full-term fetus, the normal baseline FHR range is generally accepted as 110 to 160 beats per minute. Preterm babies often run a little higher, maybe 120 to 160, just due to their immature systems. This rate is maintained by a really delicate balance between the fetal central nervous system, the brain, and the autonomic nervous system, which has 2 opposing branches. You have the sympathetic nervous system, think S for speed up, which acts to increase the heart rate, causing accelerations. And then you have the parasympathetic nervous system, mainly acting via the vagus nerve, think P, for putting the brakes on, which slows the heart rate, causing decelerations. A healthy, well-oxygenated fetus keeps these 2 forces in balance, holding that baseline steady within the normal range.
Okay, so what about when the baseline deviates from that normal range? These are the alarm bells, right? Let's start with tachycardia too fast.
Right. Tachycardia is defined as a baseline FHR that's consistently above 160 BPM and stays there for longer than 10 minutes. While it's sometimes classified under the atypical category we'll discuss later, it's definitely flagged as an early warning sign. It could indicate potential fetal hypoxemia, especially if you also see the variability starting to decrease at the same time.
What are the most common reasons for tachycardia? You hear a lot about maternal temperature.
Maternal fever is definitely the #1 most common cause. If the mother has a fever, her core temperature rises, and that causes the baby's core temperature to rise too. This increases the baby's metabolic rate and oxygen needs, so the fetal heart speeds up to try and compensate. It's a direct physiological response. Beyond fever, other causes could be infection in the mother or baby, like chorioamnionitis or sepsis. Fetal anemia can cause it. Maternal hyperthyroidism is another possibility. And also certain medications or even drug use. For example, things like atropine or hydroxyzine, which are sometimes given in labor, can cause fetal tachycardia because of their effects on the nervous system. Illicit drugs like cocaine are also a known cause.
Okay. And the flip side, bradycardia too slow.
Bradycardia is a baseline FHR that's consistently below 110 BPM, again, sustained for more than 10 minutes. The absolute first critical step whenever you suspect bradycardia, something stressed in all the guidelines, is you must confirm the maternal pulse separately. Make absolutely sure the monitor isn't accidentally picking up the mother's slower heart rate instead of the baby's. True fetal bradycardia is less common than tachycardia, but it can be linked to some serious underlying issues. Things like fetal cardiac problems, congenital heart defects, or heart block where the electrical signals aren't conducted properly. Certain viral infections, like cytomegalovirus, can sometimes cause it. And also, sometimes it can happen transiently if the mother becomes suddenly very hypotensive, low blood pressure, hypoglycemic, low blood sugar, or even hypothermic, low body temperature.
Fine, baseline established. But the tracing isn't just a flat line, it's constantly fluctuating.
Yep.
You stressed earlier that variability is maybe the most important indicator of fetal well-being. Why is it considered so critical?
It is absolutely the most critical element, yes. Variability is everything because it's the direct visual sign that the baby's central nervous system and autonomic nervous system are intact, well oxygenated, and crucially, communicating properly with each other. It shows that those sympathetic, speed up, and parasympathetic, slow down forces are constantly interacting, pushing, and pulling in this dynamic balance minute by minute. It reflects neurological health. We quantify it by looking at the amplitude of the fluctuations around the baseline, basically. The difference between the highest peak and the lowest trough of the short-term wiggles in the FHR, measured in beats per minute, typically assessed over that 10-minute segment.
Okay, let's walk through the 4 classifications of variability, starting with the one we want to see, moderate variability.
Moderate variability is the gold standard. It's defined as an amplitude range fluctuations between 6 and 25 beats per minute. This is considered normal, reassuring. It's highly predictive of a normal fetal acid-base balance, meaning the baby is well oxygenated and not developing metabolic acidosis. When you see moderate variability, you can be pretty confident the fetus has good physiological reserves and is coping well.
Okay, so that's the ideal. What happens when that communication starts to falter and the variability decreases?
Below moderate, the next level down is minimal variability. This is where the amplitude range is 5 BPM or less, but you can still actually detect some fluctuation. It's not completely flat. Now, clinically, minimal variability definitely makes providers pay close attention. It causes some anxiety, but the sources note it can often be temporary or have benign causes. Common reasons include a normal fetal sleep cycle. Babies sleep in cycles of about 20 to 40 minutes in utero. Certain medications given to the mother, like sedatives or narcotics, can dampen variability. And fetal prematurity can also be a factor, as the nervous system isn't fully mature. Guidelines often suggest that minimal variability might be tolerated for maybe up to 80 minutes, but honestly, most practitioners are going to be investigating or intervening well before that point if it persists, especially if there are other concerning features on the tracing.
And then the most concerning classification, absent variability.
Absent variability is the real crisis signal. This means the amplitude range is essentially undetectable, usually defined as 0 to 2 BPM. The line looks virtually flat. This signifies severe depression or a non-functioning central nervous system, almost always due to significant or prolonged hypoxemia and developing metabolic acidemia. It indicates a critical breakdown in that vital sympathetic-parasympathetic interplay. Absent variability requires immediate, urgent intervention.
And finally, there's the opposite end of the spectrum,
Yeah.
mark variability. What does that signify?
Marked variability is when the amplitude range is greater than 25 BPM. The tracing looks really erratic, chaotic, with wide swings. While sometimes this can just be a normal variant for a particular fetus, it can also be a warning sign. It might indicate early or mild fetal hypoxia, where the nervous system is sort of overreacting, giving this exaggerated, frantic response to brief interruptions in oxygen. It's sometimes seen with things like sudden cord compression. It definitely warrants increased vigilance and consideration of potential causes, and maybe initiating some intrauterine resuscitation measures just in case.
All right, so we've got baseline and variability down. Now we look at the specific events that interrupt that baseline. Let's start with the good news. Accelerations. You call these the reassuring sign.
Yes, accelerations are generally very reassuring. They're defined as a visually apparent, abrupt increase in the FHR above the baseline. And abrupt means the time from the onset of the increase to its peak is less than 30 seconds. It's a quick rise. For a term fetus, over 32 weeks, the peak of that acceleration must be at least 15 BPM above the baseline, and the whole event needs to last for at least 15 seconds, but less than 2 minutes. Their presence, especially if they occur spontaneously or in response to fetal movement, is highly predictive of fetal well-being. It shows an intact, oxygenated nervous system that's responsive.
You mentioned the duration there, less than 2 minutes. What if an acceleration lasts longer? When does it stop being an event and become a change in the baseline itself?
That's an important distinction. If an acceleration that rises above baseline lasts for more than 2 minutes but less than 10 minutes, we classify it as a prolonged acceleration. Still generally reassuring. However, if that elevated heart rate persists for more than 10 minutes continuously, it's no longer considered just an event. It's formally defined as a true change in the baseline FHR. At that point, the clinician needs to reassess and establish that new, higher rate as the current baseline.
Okay, now for the decelerations, the drops in FHR, driven by that parasympathetic slowdown response, we often categorize these using that helpful mnemonic, head, cord, placenta. Let's start with H for head early decelerations.
Right. Early decelerations are generally considered benign. They are thought to be caused by head compression as the baby descends into the pelvis, especially during contractions. Visually, the key thing about early decels is that they are gradual. The onset to the lowest point, the nadir, takes 30 seconds or more. They are symmetrical, like a smooth bowl shape. And crucially, they mirror the contraction perfectly. The nadir of the deceleration lines up exactly with the acme, or peak, of the uterine contraction on the tracing below. They start when the contraction starts and when it ends. It's thought to be a simple vagal nerve reflex due to the head squeeze, and it's considered a normal physiological response in active labor. No intervention needed usually.
Okay, so earlies are usually okay. Now,
Yeah.
P for placental-lake decelerations. These are the ones that indicate more serious physiological stress.
Right. Yes, late decelerations are much more concerning because they typically indicate uteroplacental insufficiency. Basically, the placenta isn't delivering enough oxygen to the baby to meet its needs during the stress of a contraction. Like earlies, they are also usually gradual decreases, onset to nadir, 30 seconds. But the critical difference is the timing relative to the contraction. A late deceleration begins after the contraction has already started. Its lowest point, the nadir, occurs after the peak of the contraction. There's a noticeable lag. And often the heart rate doesn't return fully to the baseline until well after the contraction is finished. Seeing repetitive late decelerations, especially if they're combined with minimal or absent variability, is a really ominous sign. It strongly suggests the baby isn't getting enough oxygen and is potentially developing metabolic acidemia. This pattern requires immediate attention and intervention.
Got it. Lagging behind the contraction, late placental issue equals bad news. Okay, last one. C for cord variable decelerations.
Variable decelerations are the most common type you'll see during labor. They're thought to be caused primarily by umbilical cord compression. Their defining visual characteristic is their abruptness. The drop in FHR from onset to nadir is rapid, less than 30 seconds. And the drop itself must be at least 15 BPM below the baseline and last for at least 15 seconds, but usually less than 2 minutes in total duration. They often look jagged or sharp on the tracing, maybe shaped like a V or a W or a U. And importantly, they can occur with contractions or sometimes completely independent of them, which makes sense if the cord is just getting squeezed intermittently, perhaps due to fetal movement or position.
Now, the guidelines seem to spend quite a bit of time differentiating between simple, maybe okay variable decelerations and ones that are considered complicated or high risk. What are the specific visual features that push a variable decel into that more worrying category?
Yes, this is where sharp clinical judgment really comes in. You need to assess the characteristics of the variable D cells carefully. So, uncomplicated variables might be occasional isolated events. They have that characteristic abrupt drop, but then they have a quick, abrupt return right back to the baseline, often with little shoulders, slight accelerations before and after the dip. These are generally tolerated okay if variability is good. Complicated variables, however, are much more concerning. These have features suggesting the fetus is losing its ability to compensate. This includes things like the deceleration failing to return promptly to the baseline after the contraction ends, a slow return to baseline, loss of those shoulders, or becoming repetitive may be occurring with more than 50% of contractions. And especially concerning is the depth and duration of the variable.
Can you define that severity more concretely? What numbers flag it as severe?
Yes, the guidelines give specific numerical criteria for a severe or complicated variable. It's usually defined as a variable deceleration that lasts 60 seconds or longer and drops down to 60 BPM or less. Or another definition is if the FHR decreases by 60 BPM or more below the baseline level, regardless of the absolute nadir. So these really deep, sustained drops, especially if they're happening frequently, and particularly if the baseline variability is already minimal or absent between them, strongly suggest significant cord compression is compromising oxygenation and the fetus's reserves are running low. This signals impending acidemia and requires action.
Okay, and that leaves one more deceleration category, prolonged decelerations. How are those defined?
A prolonged deceleration is defined purely by its duration. It's a visually apparent decrease in the FHR of at least 15 BPM below the baseline, which lasts for more than 2 minutes, but less than 10 minutes. So it's longer than a typical late or variable, but not long enough to be considered a new baseline yet. These are significant events. They represent a major challenge to the fetus's oxygen supply. A prolonged decel is a red flag demanding immediate investigation of the cause, like maternal hypertension after an epidural, uterine hyperstimulation, cord prolapse, and rapid initiation of intrauterine resuscitation measures. And the clock is ticking. The moment that deceleration hits the 10-minute mark, it's no longer classified as a prolonged deceleration. It officially becomes a change in the baseline rate, usually to bradycardia, which typically necessitates moving very quickly towards delivery if resuscitation efforts aren't successful.
Wow. Okay, so this really brings us to the core challenge of FHS, doesn't it? It's not just about knowing the definitions. It's about synthesizing this complex interplay baseline, variability, accels, decels all happening at once, and applying sound clinical judgment. The nurse's role right there at the bedside seems absolutely critical. They're the ones integrating all this data in real time.
Absolutely. Synthesis is the art and science of FHS. It's taking all those individual pieces and seeing the whole picture of fetal status. The guidelines try to help structure this complex judgment by simplifying the overall tracing pattern into three main categories. These categories then directly guide the necessary speed and type of intervention. We're moving beyond just watching the monitor to actively managing based on the pattern.
Okay, let's break down those categories, starting with the best case scenario. The normal tracing, what does that look like and what's the action plan?
A normal tracing is exactly what it sounds like. All the key characteristics fall within the reassuring parameters we've discussed. You've got a baseline FHR between 110 or 160. You have moderate variability, 625 BPM. Accelerations might be present or absent. That's okay. And crucially, there are no late or complicated variable decelerations. Maybe some early decels, but nothing concerning. The action plan for a normal tracing. Basically, continue routine supportive care, help the mother with position changes for comfort, encourage hydration, and just keep monitoring as per the schedule. No specific interventions are usually needed because the tracing is highly reassuring about fetal oxygenation.
Okay, straightforward enough. Now, moving into the gray zone,
Hmm.
the atypical tracing. You mentioned this is where clinical anxiety and judgment really peak because it's not clearly normal, but not yet definitively abnormal either.
Hmm.
What features put a tracing in this category?
Right. Atypical is that intermediate zone that requires heightened vigilance and often some preemptive action. This category gets triggered by features that are moving away from normal but aren't yet critical. This could include things like a baseline that's slightly tachycardic, maybe 161, 170, or bradycardic, maybe 100, 109, but variability is still moderate. Or, more commonly, you might see minimal variability, A5 BPM, but it hasn't become absent yet. Or you might see recurrent variable decelerations, but they don't quite meet those complicated criteria we discussed. Maybe they're not super deep or prolonged, or maybe occasional late decelerations, but variability is still good. The key here is often the combination of features. One atypical feature might be okay, but two or more together really increase the concern.
So when faced with an atypical tracing, What are the immediate steps a nurse needs to take? What does initiating intrauterine resuscitation actually involve?
Okay, so when that tracing looks atypical, the first step is to try and figure out why and correct any reversible causes. The standard sequence of intrauterine resuscitation measures aims to improve fetal oxygenation by targeting those four physiological goals. We'll summarize shortly. The steps usually include 1. Change maternal position. Often rolling the mother onto her left or right side can take pressure off major blood vessels or the umbilical cord. Sometimes putting her on hands and knees helps. 2. 5B fluid bolus. Giving a rapid infusion of intravenous fluids can help increase the mother's blood volume and potentially improve placental perfusion. 3. Supplemental oxygen. Administering oxygen to the mother via a non-rebreather mask, usually 810 Illimin, aims to increase the oxygen saturation in her blood, hopefully leading to more oxygen crossing the placenta, though it's worth noting the routine use of oxygen is a bit controversial now, unless the mother herself is hypoxic, but it's still commonly done. 4. Decrease uterine activity. If the mother is receiving oxytocin, pitocin, to stimulate contractions, and the tracing is atypical, especially if there are decels or concerns about hyperstimulation, standard practice is often to decrease or stop the oxytocin infusion immediately. This allows the uterus to relax more between contractions, improving blood flow and giving the baby more recovery time.
That sounds like a pretty comprehensive set of immediate actions. What happens next?
Right. After initiating those steps, the nurse needs to reassess the tracing continuously. They absolutely must notify the primary healthcare provider, doctor or midwife, about the atypical tracing and the interventions started. Depending on the situation and local protocols, they might consider further fetal evaluation. One common technique is fetal scalp stimulation. Gently stimulating the baby's scalp during a vaginal exam, if it results in an acceleration on the tracing, that's generally very reassuring. But if the atypical pattern persists despite these measures, or if it starts to deteriorate further towards abnormal, then the team needs to start preparing for the possibility of an expedited birth.
Okay, which brings us to the final, most urgent category, abnormal. This signals an imminent threat to the fetus, right? What defines an abnormal tracing?
Yes, an abnormal tracing indicates a high probability of fetal hypoxia and acidemia, requiring immediate, decisive action. This category includes the most concerning patterns we've discussed, things like absent baseline variability, flatline, especially if it's accompanied by recurrent late decelerations or recurrent severe complicated variable decelerations, or a persistent bradycardia, baseline below 100, 110 for 10 minutes, or that prolonged deceleration we talked about that lasts maybe beyond 3 to 5 minutes and isn't resolving. A sinusoidal pattern, a smooth, undulating wave-like pattern, also falls into this category and is very ominous, often associated with severe fetal anemia or hypoxia. Basically, these are patterns suggesting the fetus is no longer compensating.
And the response to an abnormal tracing, is immediate delivery the only option?
The response needs to be rapid and coordinated. You must urgently review the entire clinical picture. How far along is labor? Are there other factors? You aggressively continue or initiate all those intrauterine resuscitation measures we just talked about. Simultaneously, you have to mobilize the full team. This means calling for the obstetrician, the anesthesia team, the pediatric neonatal team to be ready for resuscitation after birth. Everyone needs to be aware and preparing for an urgent delivery. Now, is delivery always mandated immediately? Not quite 100% of the time, but the strong bias is definitely towards expediting birth, either inducing labor rapidly if possible, assisting with vacuum or forceps, or moving to an urgent cesarean section unless there's a very rapid and sustained improvement in the tracing back towards atypical or normal following resuscitation efforts. The only real exception where you might delay immediate delivery with a persistent abnormal pattern is if you have access to and use further fetal assessment tools like fetal blood sampling, FBS. This involves taking a tiny blood sample from the baby's scalp to directly measure its pH or lactate level. If that sample comes back showing normal oxygenation status despite the ugly tracing, the team might decide they have a bit more time. But FBS isn't available everywhere, and if the pattern persists or the FBS is abnormal, delivery needs to happen promptly.
You mentioned the four physiological goals of intervention earlier. Can you just quickly summarize those again? What is every resuscitation step fundamentally trying to achieve?
Absolutely. Every single one of those maneuvers, position change, fluids, oxygen, stopping pitocin, is aimed at improving the situation in one of four key physiological areas to reverse or prevent hypoxia. 1. Improve uterine blood flow. Get more oxygenated blood flowing to the placenta, primarily achieved by maternal position changes to relieve pressure on her major arteries and veins, like the aorta and vena cava. Also helped by IV fluids if she's dehydrated or hypotensive. 2. Improve umbilical blood flow. Ensure blood can flow freely through the umbilical cord between the placenta and the baby, achieved mainly by maternal position changes that might shift the baby or uterus and relieve any cord compression causing those variable decelerations. Sometimes amnioinfusion, putting fluid back into the uterus via an IUPC, is used for this too, though less common now. 3. Improve maternal fetal oxygenation. Increase the amount of oxygen available to be transferred across the placenta. This is the rationale behind giving the mother supplemental oxygen or correcting things like maternal hypotension that might reduce oxygen delivery. 4. Decrease uterine activity. Give the baby more recovery time between contractions. This is achieved by stopping or reducing oxytocin, or sometimes by giving a tocolytic medication, like terbutaline, to temporarily stop or slow down contractions if the uterus is contracting too frequently or not relaxing enough, hyperstimulation tachysystole. Hashtag tag outro.
Wow. Okay, this deep dive has certainly unpacked a lot about the intricate world of fetal health surveillance. I feel like you, our listener, now have a much better toolkit to start deciphering that language of the fetal heart. We've covered the benefits and technique of the hands-on IA approach, the objective data you can get from EFM, especially with an IUPC and calculating MVUs, and most importantly, we've broken down how to interpret that crucial baseline, the 4 key levels of variability.
And hopefully you've got a clearer handle on the physiological causes behind those 3 main deceleration types, thinking head, cord, placenta, and also that critical sequence of intrauterine resuscitation steps needed when the tracing shows signs of fetal stress. That understanding really is the bedrock of safe, effective care during labor.
So as we wrap up, here's our final provocative thought for you to mull over, building on what we discussed. We highlighted that paradox, right? Continuous EFM gives us so much detailed information, yet it's associated with higher rates of intervention, particularly C-sections, in low-risk women. The goal is obviously to reduce harm, but could the very act of continuous monitoring in some cases inadvertently increase exposure to the risks of intervention, like surgery, without a clear corresponding benefit for the baby?
It really puts practitioners in a challenging spot, ethically and clinically. How do you interpret that atypical tracing? Do you react immediately to every potential, maybe transient abnormality? Do you start that cascade position change, fluids, oxygen, stop the pitocin, call a provider, maybe start thinking C-section? Or do you place more trust in the overall clinical picture in the presence of that reassuring moderate variability, maybe hold off on some interventions to see if things resolve, and try to avoid the potential harms of intervening unnecessarily? It's this constant, difficult negotiation, isn't it, between leveraging information to maximize safety and the potential to cause harm through over-intervention.
A critical balance indeed, something every practitioner grapples with. Well, thank you so much for joining us for this really insightful deep dive into fetal health surveillance.